All right. Thank you again, everybody, for dialing into our Ask the Doc headache awareness. All lines will be muted for the remainder of the presentation, and we will have a question and answer portion of the presentation at the end, where we encourage you to type your questions in for our presenter. Alongside Men's Health Month, June is also a time where we can look at the impact that headaches have on the public. During Headache Awareness Month, we aim to shine a spotlight on a disease that affects more than 1 billion people worldwide, yet remains widely misunderstood. Despite being the second leading cause of global disability, migraines continue to be stigmatized, underdiagnosed, and undertreated. To help us understand and navigate this topic better, we are joined today by Dr. Jennifer Evan. Dr. Jennifer Evan is a board certified neurologist and UCNS-accredited headache medicine subspecialist. She completed her medical training at Indiana University School of Medicine, followed by residency in neurology at the Johns Hopkins Hospital in Baltimore, Maryland. She then went on to complete a fellowship in headache medicine and facial pain at the University of Colorado, after which she stayed on to join the faculty as an assistant professor of neurology for 3 years. Her role also included working as an attending neurologist, staffing the neurology resident clinic. She currently works at the Jesse Brown Veterans Affairs Medical Center in Chicago and practices in Northwest Indiana. She is passionate about telemedicine and teleneurology domains to help patients access subspecialist care regardless of geographic location and commute demands. Her other clinical interests include education and teaching, as well as treating vulnerable patient populations, including those with headache and facial pain management during pregnancy. And Dr. Jennifer Evan, I'll transfer it over to you.
Thank you so much for that introduction. And hello, everyone. I'm very happy to be here and giving a talk on one of my favorite topics that I'm very passionate about, which is headaches. And I think it's a great topic that, everybody should know as much as they can about because, as you mentioned, it is a very common condition. Over 1 billion people worldwide. And if you don't have headaches yourself, guaranteed you know someone who has headaches or bad headaches. So I think it's a very important topic that we all can learn about. So here's a little summary of what we'll talk about today for the talk. We are going to talk about all the types of headache disorders, the most common types of headache disorders that exist that we see. We are going to talk about whether you need a head scan, like an MRI or a CT, which is a common question. We are going to talk a little bit about what treatments there are for headaches, depending on what type of headache, and then we'll give you some tips to take away from the talk today on how you can lower your risk of headache and treat your headaches as best as you can. So we'll start off with a very common kind of complaint. Having a headache has actually been found to be one of the top 5 most common conditions that a patient goes to their primary care doctor for. It's also one of the most common presentations for emergency rooms. And then, of course, as a neurologist, headache disorders is one of the most common neurological disorders that we see, certainly more common than things like seizure and epilepsy, multiple sclerosis, etc. So it's a very, very common condition that exists in a huge number of people, both in the United States and worldwide. The Global Burden of Disease study has shown that tension type headache is consistently ranked as the number 2 most common medical condition worldwide. So only thing that is more common than tension type headache is dental caries. So you've got a headache. Now what? So what? Everybody has a headache. What do? Should you be worried about it if you have a headache? Is there too many headaches that should make you worry if you have too many or if you can't treat them? How do we approach this topic when we know that it's so common and a lot of people have it? What do we do? So number 1 question I get as a headache medicine specialist is it normal to have headaches? Or the reason why I didn't go in sooner was because I thought it was normal to have headaches. Doesn't everybody have them? So there's nothing to do about them. It's normal. Everybody gets them. So that's a good question. Is it normal to have headaches? Yes and no. With the main answer being no, technically it's not normal to have headaches. We talked about how it's common for people to have headaches, and there are different types of headaches we're going to see and talk about, but technically it's not quote unquote normal. It's a common thing for the body to have, but I like to tell my patients, and I like to think of it as it's your body telling you that something might be off that needs attention health-wise in your body. So when the covering of the brain or the meninges creates pain where we have our nerves, That's telling you that the reason those headache nerves are triggered is because something possibly is setting them off. What that something is can vary and can be a number of reasons, but a headache is telling you that your body needs something. So if you're only having a few headaches or rare headaches, then you may not need much of any attention, because you're right, it can be normal to have a few headaches. There's things like dehydration and busy lives and stress. Those are all pretty normal to cause some headaches. But when you have headaches that are either frequent or severe, or any other number of features that we'll talk about here in this talk, you may want to make an appointment with your primary care provider. Your primary care provider is going to be pretty much everyone's first step if you're having concerns about whether your headaches are normal or abnormal or what can be done for headaches. Primary care doctors are the gatekeepers. They are going to be the best to assess things at face value and refer you to the appropriate next provider or specialist. So not everybody who has headaches is going to end up needing a neurologist or a headache medicine specialist like myself, but your primary care doctor may actually be quite well versed in evaluating your headaches and determining what could be the cause. That's going to be my recommendation for everyone's first step if you have any concerns. For some people, their primary care provider is their women's health provider, like an OBGYN. It could be your pediatrician that some people stay with even for a couple years after turning 18. But your primary care provider is going to be your first step to talk about any concerns for headaches. Next, we're going to kind of focus on what are the main types of headaches. So if you look at headaches as a whole, there are several dozen types of headaches, and we tend to split the types of headaches into two main categories or two main boats. One category is what we call primary headache disorders. And primary headache disorders, you can think of them as coming about on their own. Nothing really is causing them per se, but they are a primary condition that could persist throughout one's life, similar to the way someone might have high blood pressure or diabetes. Whereas the second boat is called secondary headache disorders. And secondary headache disorders, as the name implies, are headaches that are secondary to something else in the body or caused by something else in the body. So a little bit of a fine difference there, but secondary headache disorders are much less common as a whole when you think about people who have headaches. And that's a good thing, because we don't particularly want to find bad or scary things when someone's having headaches. So if you look at all the people in the world that have headaches, it is much, much, much less likely to find a secondary headache disorder cause. The vast majority of people who suffer from headaches, particularly chronic headaches, and by chronic we mean that you're having either a lot of them or you've been having them for a long time, the majority of people are going to have what's called a primary headache disorder. And the three main types are listed here. The first being tension type headache, which probably everybody has heard of that. And there's a high chance that a good number of people have experienced a tension type headache. It is, like I mentioned earlier, second most common condition in the Global Burden of Disease Study worldwide. And that is the most common headache disorder. The second most common primary headache disorder is migraine, which again, odds are that you have heard of that or know someone with migraine or personally have migraine. And then the third main category of primary headache disorders is quite rare, and it's called cluster headache and the cluster headache related syndromes. And those ones we see less than 0.5 to 1% of the population having. So certainly not common, but it is a well-known headache condition that people do have and there are treatments for. So the vast majority of people who see us in neurology or headache medicine are going to have tension type headache or migraine. And then there's, like I mentioned, dozens of secondary headache disorders, which we'll also talk about coming up. On the right, you'll see some common symptoms that can occur when someone has a headache. And if you look at the color matching of each symptom, you can kind of see which primary headache syndrome you're most likely to see it in. The ones in purple can be seen in both tension type headache and migraine. So light sensitivity and sound sensitivity are what we call non-specific, meaning they are common symptoms for people to have when you have a headache. And they can occur in tension type headache. They are not necessarily only a migraine feature, even though they are part of the migraine criteria. In red, you'll see nausea vomiting, which is a very well-known and classic migraine symptom. So if you do have a headache where you have nausea and vomiting, that increases the suspicion and the chance that this is a migraine headache. And sometimes the nausea may not be as obvious. It could be a subtle queasiness, but that also does count as the migraine headache. And we do not usually see nausea or vomiting in tension type headaches. There are some differences between the type of pain that a tension type headache versus a migraine tends to be manifested with, whether it's throbbing or pulsatile or pounding, which tends to be more of a migrainous quality, versus whether it's squeezing or tight or sore, which tends to be more of a tension type headache quality. Um, Tension type headaches tend to be mild to moderate, while migraines tend to be moderate to severe, but those are only generalizations, and there's a lot of wiggle room there as far as the severity of the headache pain itself. And then both headaches could get worse with different sorts of movement and activity, but migraine is the one that classically you are not able to do basic daily activities with, whereas tension type headaches, you may be able to do normal movement and activities with. And then there's a lot of, quote unquote, weird or extra symptoms that can come with migraine headache. And these are things that can include dizziness, imbalance, vision changes, double vision, changes to your speech, sensory issues. And those ones would absolutely not be something that I would see in a tension type headache, but can be not rare in migraine headache. We won't talk too much about cluster headache because, again, like I mentioned, it is quite exceedingly rare in the general population. So cluster headache is not commonly encountered. And of course, if someone has cluster headache, they do need to see a headache medicine specialist, not a primary care doctor or a general neurologist. So just a little bit about tension type headache first. So again, it's typically a mild to moderate headache. It is not aggravated by routine activity. It does tend to have a little bit of a preponderance towards the afternoon or later part of the day. And it does have a criteria in our international classification of headache disorders for having some triggering or activation from the muscles in the neck and shoulders and back of the head. They call that myofascial pain, or basically just meaning soreness to touch or tenderness or movement to the muscles in the neck and shoulders. So if you notice that either rubbing the neck and shoulders helps, or if you touch a certain area that a headache gets triggered by a knot or a tender or a tight spot in the neck and shoulders, or it's sensitive to pain, that might be a trigger or a feature of tension type headache. We tend to think these types of headaches happen from things like neck and shoulder posture changes, having the shoulders too rounded, or staying in one position for too long, which can happen with stress and a lot of desk jobs. And tension type headaches, although they are the most common primary headache disorder globally, they are not usually seen by a headache medicine specialist too often. And that's because they typically are treated with over the counter medication and with rest. So they are not as debilitating as migraine. While they can present some disability, we do not typically see as much of a disabling impact with tension type headache compared to migraine and some of our other headache disorders like cluster headache. So tension type headaches, they may be encountered by primary care doctors, and some people may find out that they have tension type headaches because of these features. They may take an Excedrin over the counter, Tylenol, ibuprofen, rest in a dark room, or do some stretching and find that the headache feels better. And those would all be positive features of tension type headache. Next, we're going to talk a little bit about migraine. And the first thing I want to point out is that there is a little bit of a misconception in the field of neurology and headache medicine and among the general population that migraine is just a headache. But what I want to, you know, take home is that migraine is not just a headache. Migraine is a pretty complex neurological disorder that we have a wealth of information about, from imaging studies to functional studies to biochemical serial markers in the blood, where we can see changes in the brain, in certain areas of the brain and the brainstem, and markers for migraine and proteins in the blood that can trigger a migraine attack. So it is a very distinct and complex neurological disorder. And it can come with a large range of associated symptoms that are part of the migraine attack, as well as part of what we call the prodrome, or what comes before the migraine attack starts, and what comes after the migraine attack, or the postdrome. So one of the messages that I hope we all sort of understand and take home is that migraine is not just a headache. It actually is quite a complex process that can affect multiple systems in the body. Some of the more common migraine symptoms are light sensitivity, sound sensitivity. People can have dizziness or vertigo. They could have a type of migraine where they get what's called an aura, and that aura could be a visual change, like jagged lines in the vision, or a missing spot of their vision. They could have sensory changes or numbness or tingling on one side of the body. They could have changes to their hearing and smell. You could have sensitivity to certain odors. People can even have trouble speaking with a migraine attack. And then, of course, there's other symptoms like fatigue, mood changes that have been documented. And again, that hallmark nausea, vomiting, which is a part of the biochemical cascade of what a migraine attack is. So as you can see here from this diagram, migraine is not just my head hurts or a head pain. There is a whole lot of other symptoms that are distinctly part of what a migraine headache is. And there are a lot of subtypes of migraine. So not everyone's migraine looks the same, and not everyone's migraine has all of these symptoms. So another thing to remember is, even if you don't suffer from migraines, or you know someone close to you, a family member or a friend who has migraine, not every person's migraines are the same as anyone else's. So each one may share some common features, but there may be extra features or lack of symptoms, and each migraine attack itself could be different within the same person. The other thing I want to mention is that the visual aura with those jagged lines and missing vision I mentioned is not something everybody with migraine has. And in fact, only a small percentage, roughly 10 to 15% of people with migraine have aura. And that certainly is something that you may want to discuss with a neurologist, because migraine aura, or these distinct visual changes that happen during a migraine attack, could be something that can cause complications or change your risk of certain events happening. So that would be a good thing to talk about with a medical provider if you're concerned you might have migraine aura. So just from talking about the two most common primary headache disorders, you might be thinking, so big deal, can I just treat my headaches myself then? Yes, you can, and people do, right? You don't always need to see a primary care doctor or a neurologist or a headache medicine specialist to treat your headaches appropriately or adequately. But if you're taking medication, like an over-the-counter medication, like a non-steroidal anti-inflammatory drug, those are things like Motrin, ibuprofen, naproxen, Excedrin, acetaminophen. If you're taking something over the counter more than 2 to 3 times a week consistently, you may want to consider talking to your doctor or asking for a referral to a headache specialist to discuss other treatment options. And there are reasons for why I say that. Like I mentioned earlier, it is somewhat normal to have had a headache at some point in your life, but we start to worry when someone's headaches are frequent or consistent or disabling to their life or affecting their quality of life. So while it isn't normal per se to have headaches, it is common and normal to have had one or occasional headaches, but we worry when they're more than just occasional. So whether you have an alarm feature or you're concerned you have a unique or rare headache syndrome, you could have quote unquote regular headaches or normal headaches, like my patients tell me. But if they are too frequent, we do want you to see a provider, whether that's a primary care provider or a neurologist, a general neurologist, or a headache medicine specialist, which sometimes it can be hard to see or find a headache medicine specialist. But that would be a good reason too. If you notice any of those things, too many headaches, too much over the counter medication, you're worried about how much your liver or kidneys are processing with all of the ibuprofen, you always have to keep your over the counter medicine on hand. Those are signs you should talk to someone about your headaches. There's also another sort of concept that we worry about when someone says, well, I get a lot of headaches, but I treat each one with my over the counter medicine of choice. Two things we worry about is over time, that can sometimes damage the kidneys if you're treating too many headaches with an over the counter. And there's another phenomenon called medication overuse or adaptation headache. That just means that if you're treating too many headaches more than 3 times a week, so 4, 5, or 6 or 7 times a week, even if you're treating them adequately with an over the counter, over time your body can actually adapt to that chronic headache syndrome and create a more daily, less responsive headache. So the take home message here is if you are having a lot of headaches or feeling like you always need to have your over the counter medication near you, I do urge you to talk to your medical provider about your headaches. So now we're going to talk about what we call in the neurology world red flags. And that just means things that we would do a hard stop or a hard pause to think about someone's case a little bit more thoughtfully, or possibly we need to do more workup or imaging. So a red flag would be any of these listed here, which I'll go through. Some of the most common things are if someone comes to me or their headache doctor or their primary care doctor and says, I'm starting to have headaches, and they're older than age 50, but they were not someone who struggled with headaches in their teens, 20s, 30s, or 40s, or they never really had headaches. And now all of a sudden they're over age 50 and they're starting to have regular headaches. Absolutely something you need to talk to your doctor about. That is considered a area of caution that requires some workup and thought. If you have a history of cancer, even if it was resolved or in remission, and you start to have headaches, that's something you need to let your healthcare provider know about. If you have a history of immunodeficiency, immune system problems like HIV, that's something you need to let your doctor know about if you're having new or different types of headaches in that context. If you have what we call an abnormal neurological exam, so if a doctor or a neurologist sees you and something is not what it should be when they check a cursory neurologic exam, that could be loss of sensation on your face, an eye that doesn't move how it's supposed to when you're tracking an object. It could mean you're losing sense of your peripheral vision and you don't think that you're able to see as well on the outside. It could mean weakness in an arm or a leg. So an abnormal neurological exam in the context of headaches or new headaches or a change in headaches would be something we need to know about. If you have what's called a thunderclap onset, and of course with all of our recent storms in the region, this is probably all too familiar, but that just means a headache that reaches maximal intensity or maximal volume, you can think of, within 5 seconds. So it's a very sudden, intense onset headache. This is not a headache that someone says, I can feel it starting in 20, 30, 40, 50 minutes later. It's really bad and severe and 10 out of 10. This is a thunderclap, okay? So that absolutely warrants telling your provider about, your primary care doctor, getting a referral to a neurologist, and talking about if you have a thunderclap onset headache. If you have a history of a clotting disorder and you're having new or different headaches, that's something I want to know about. If you are pregnant and you have new or worse headaches, absolutely something you need to tell your OBGYN provider about, your primary care provider, tell anyone about, because you absolutely need to be seen medically. That can be a warning syndrome. It does not always end up in a bad situation. I do want to bring home that point, that headaches in pregnancies are not always scary or bad or caused by something dangerous, But to rule out any concern of a bad cause for new or different headache in pregnancy, you absolutely need to make sure one of your medical providers is aware. If you have new headaches in the context of a fever or a recent infection, particularly of the face or mouth or jaw, or any recent surgery, you absolutely need to tell your doctor or go to an urgent care or an emergency room to be evaluated. And lastly, if you are someone who has had headaches for a long time, not super frequent, but also not super occasional, you're a headachy kind of person, but your headache has changed its pattern or its qualities or its features, and that could include things like now the headache has changed when you're sitting upright versus laying down, or if you do a certain activity like coughing or sneezing or bearing down and the headache changes or worsens, you need to let your doctor know. And these are things that we consider red flags, which means we need to think about it a little bit more and do a little bit of a workup. So you heard me mention earlier that we have secondary headache syndromes, and that just means that unlike the primary headache syndromes, which can come about and are not necessarily quote unquote caused by anything in particular, secondary headache syndromes, like the name implies, are caused by an underlying cause. So people can have headaches if they have poor sleep, like untreated sleep apnea or sleep deprivation. They could have headaches if you're leaking spinal fluid from a procedure or a surgery in your spine. You could have a secondary headache if you have high blood pressure that's untreated and your blood pressure is in the 160s, 170s, 180s, 190s systolic. Of course, you can have headaches secondary to a mass in the brain, which I think is a lot of the times people's biggest fear when they come to me as a neurologist or a headache neurologist. They tell me I probably have a tumor. And that is not a common cause, thankfully, of headaches, but it is a possible cause, unfortunately. Other things that can cause secondary headaches are things like if you have arthritis in the neck, or what we call cervicogenic headaches can develop. If you have an infection of the head or neck or sinuses, that can absolutely cause headaches secondary to that infection. If you have a problem with a blood vessel in the brain, like an aneurysm, that can cause headaches, certainly. If you have a head injury, like a mild traumatic brain injury or a concussion, you absolutely can have headaches after that. If you have a jaw or a dental cause, the most common I think would be temporal mandibular junction disorder, or TMD, and that can cause pain in the face and even headaches. If you're dehydrated, you could get a headache. If you have toxins, a famous one would be alcohol or substances that can absolutely cause a headache secondary to the chemical or the substance. Medication side effects. So that would not be a primary headache syndrome. That would be secondary to the medication causing it as a side effect. So the one thing I want to reiterate though is that the majority of headaches that people have are not really secondary headache syndromes. They are primary headache syndromes, like tension type headache and migraine overwhelmingly is more popular than a secondary headache. But secondary headaches, as you can see from this list, are not always dangerous or bad or scary. Sometimes they are very treatable, and the headaches get better when you treat the secondary cause. So now we'll move towards a very, very common question that a lot of people have said to me and a lot of people think about. I need an MRI. I need a picture of my head. I have headaches. I have way too many headaches. Something must be causing them, and I need imaging of my head. And that's going to find what's causing it, and I can get rid of whatever's causing it, and my headaches will go away. But do you really need an MRI? So as a neurologist and as a headache medicine specialist, fortunately, we have guidelines to help determine when someone does or does not need an MRI or a head scan, like a head CT scan, to work up the cause potentially of their headaches. And that goes a little bit back to that red flag list we talked about. Certainly, if someone is having one or more of the red flag features on that list, imaging may be indicated. But if you do not have one of the red flag indicators on that list, and you are someone who has had headaches or a history of headaches for 5, 10, 15, 20, 25 years, and they are about the same as they have always been since you were a teenager or in college, and now you're in your 40s and you decided to do something about them because you can't take ibuprofen anymore, or your spouse is urging you to go in and be seen for your headaches because you're not able to make the social events or the family events. You may not need an imaging study of your head as part of your workup, which I think is important to know because sometimes people worry about imaging studies. A CT scan technically has radiation that we don't want to expose people to if we don't truly need to see a CT scan of someone's head. And an MRI does not have radiation, but is a much longer and involved scan that requires scheduling, and you have to stay still for 30, 40, 50 minutes. So we certainly don't want to be subjecting people to scans willy-nilly, so to speak, only if they truly need it or have an indication for it. And we try to use the data in our field to guide us on whether someone needs a scan and what kind of scan they might need. What are we looking for, or what are we worried about? So you do not have to worry if I see a headache neurologist or a neurologist and someone's going to order a scan for me and I don't want one. You may not need a scan. That's a discussion based on each person's individual case. Here is a study I just want to talk briefly about. When people with a headache present to the emergency room, which is a little bit different than someone who gets headaches frequently and is seeing an outpatient clinic appointment, whether it's with their primary care doctor or a neurologist or a headache medicine specialist. But these are people who, whether they have had headaches in the past or they have a brand new headache that suddenly presents that's severe, or a thunderclap or what have you, but they go to the emergency room and they present to the emergency room with a headache. So these are not your typical, I've had headaches for 20 years, run of the mill, I'm going to wait for my headache appointment outpatient. These are a specific type of headache that is bringing you to the emergency room. So in a large study of over 300 people, middle-aged people, when you're going to the emergency room, of course, a provider is going to look at you and do a neurological exam. But of the people who are presenting to an emergency room setting, just under half of them did have a neurological sign or symptom on their exam. And as you can see here, imaging was done in about 80% of them, of the patients in general, even though only half of them had a change in their neurological exam. But because you're presenting to the emergency room, which is a pretty urgent setting, you're going to usually get an imaging study most of the time. And it looks like it's a pretty equal matching of whether they're doing a head CT versus an MRI in the emergency room. Or some people, half of them had both scans done. But the imaging was only abnormal in 1/3 of the people. And again, this population was people who had a very sudden or extremely severe headache that was unlike any ones that they've had in the past that they went to the emergency room for evaluation for. So this is a more atypical or severe population than just someone who's outpatient who gets a lot of headaches. And even still, you only have an abnormal brain scan in 1/3 of the people. So all this take-home point is to say, even when we do have an abnormal neurological exam or symptom or red flag, to think of it as an easier term, you still are not guaranteed to have any cause or abnormality on your imaging study. And that's something, of course, to talk about with a neurologist, but it goes back to when people see me and they say, well, something must be on my scan. It is not normal to have as many headaches or how bad the headaches are that I'm having. And whether it's fortunately or unfortunately, we do not find the cause of headaches on the brain scan very often. Most patients, especially people with primary headache disorders like tension type headache and migraine, even when migraine can be exceedingly severe with all of the symptoms we looked at earlier, all of those associated symptoms, There is no cause on a brain scan, no tumor, no blood vessel abnormality, no aneurysm that's there causing the headache in the vast majority of people. So I don't want people to be scared to go to their headache provider or to their primary care provider, that they're necessarily always going to get a scan. You may not. And that if someone is ordering a scan, that means you definitely have something wrong. You don't definitely have something wrong. It could still be very nice and normal. So now you may be thinking, well, I don't have any of those red flag features, so I don't really need to see a doctor. And the headaches go away. I just take a bunch of ibuprofen. And how would I even find a neurologist or a headache specialist who could treat my headaches? And what can you guys even do about headaches or migraines anyway? And I don't want to just take pills. I'm already on enough and I'm young and I don't want to take a pill every day for my headaches. So those are all valid questions and concerns and very appropriate. And my answers to a lot of those are going to be, there are a lot of options in treating headache and who you see for headache. So you don't necessarily have to drive an hour or two to a large city to find a neurologist, even though, yes, sometimes it is hard to access a neurologist or a long wait period. And that certainly can be the case if you need a headache medicine specialist, because unfortunately there is only a few hundred headache medicine specialists in the United States. And obviously there are not just thousands, but millions of people with headache disorders and migraine in the United States. So there's just not enough headache medicine specialists to see every patient with a headache disorder. So sometimes you will be accessing a neurologist, a general neurologist, and sometimes a primary care doctor, sometimes an ENT doctor, sometimes your OBGYN. So how do you access the appropriate person? Could you see a telemedicine visit? Absolutely. A lot of providers and organizations are still seeing people via telemedicine, which allows you to not have to drive hours each way to a specialist in the nearest big city. And then as far as what can be done about headaches or migraines, pills are really just the tip of the iceberg. And of course, we do have a lot of medication available to us that is very well researched and published, rigorously tested, and we have decades and decades of research of people taking medications to help reduce headaches with successful results. So we do have a lot of options from the pill perspective, and some of those medications are going to tackle more than one medical condition. So it could help headaches and blood pressure. It could help headaches and insomnia. It could help headaches and weight loss. So there's certainly a lot of options from the medication perspective, but I do want to mention that we have a lot of non-pill or non-medication options to treat headaches. So I hope that doesn't discourage someone from seeing someone about their headaches, or assuming that they're just going to be put on a medication and there's nothing that can be done and they've had them their whole life. Certainly, there are many people who have had headaches their whole life who do still find a successful improvement in their headaches when they see a specialist or a neurologist. So there is quite a lot of potential improvement that we can do, even if you've had headaches for a long time. Some simple first steps that I want to make sure everyone knows about is everyone should avoid dehydration. And for that, we mean technically every adult should have 8 to 10 full glasses of water a day. So 8-ounce servings of water is what we need from a hydration perspective for the body. Juices and lemonade do count. Coffee is a little bit hit or miss because yes, it is a water-based beverage, but it is a diuretic, which means it makes you have to urinate. So it doesn't necessarily help with hydration too much. Teas absolutely count. Sodas do not count for hydration. Energy drinks do not count for hydration. Milk, juices, and plain water, and flavored water beverages do, and you need 8 to 10 a day. We encourage people to take breaks every few hours from whatever it is that you're doing to gently stretch your neck and improve range of motion. And that goes back to that tension type headache, which is the #2 most common medical condition globally. So it's very common to have a tension type headache with those features we went over towards the later or afternoon or evening part of the day. And what you can do to start easily at home is to take a break every couple hours and do some gentle stretching. Another kind of easy, low-hanging fruit to think about is work on your sleep. Um, think about how long you're sleeping for, what your body needs, and the quality of your sleep. Do you have obstructive sleep apnea or concerns for it? Are you waking up 2, 3, 4, 5, 6 times a night? Um, and improving sleep can absolutely improve headaches. Keep a regular schedule. Bodies and brains don't particularly love when people stay up really late one night and then you're up for 20 hours the next day and then you oversleep the next day to catch up, or you skip dinner and lunch one day, but then the next day you don't. So keeping a regular schedule can help your body have more regularity. Try to find a stress relief activity that you enjoy and try to do it regularly. And that can seem like such an easy and simple thing to think about, but it can make a big impact on the body and many systems. Try to avoid skipping meals, like I talked about. Try to keep your caffeine less than 4 servings a day. If you are needing 5, 6, 7, 8 servings of caffeine or coffee or tea or energy drinks a day, it's again something that should tell you maybe it's something I need to discuss with my primary care doctor. Why do you use so much caffeine? Is it because your sleeping is not good quality? Is it because you're trying to stay awake and could that caffeine be contributing to headaches? And lastly is get your eyes checked. Don't forget regular optical checkups, because as vision changes or weakens with age, or if we need an updated prescription on our glasses, that can absolutely contribute to frequent and more commonly occurring headaches. So it could be something as simple as just as addressing one of these kind of common healthcare steps here. So this is just a little chart that talks about all of the things, not even all of the things, still there's things that are not listed here, that we can talk about and do when someone has headaches, whether it's a tension type headache or a migraine headache or a cluster headache or a secondary headache. There are things that we can do to treat their headache pain itself. You don't have to tough it out or suffer hours with no appropriate treatment for your headache pain, or other symptoms like nausea. So on the left side, you'll see there's quite a lot of medication-based therapies, like as-needed medication that you take when a headache occurs. You could be given or discuss with your provider a daily medication to help reduce the headaches from occurring. You could be given a rescue medication in case you have a severe headache or migraine that doesn't respond to your over-the-counter. You could discuss things like onabotulinum toxin or Botox for headaches. You could discuss things like nerve blocks to help treat headaches. There are devices or neurostimulatory devices that are FDA cleared that can help treat headaches without any medication being used. There's light therapy that has been found that could be helpful for certain people. There's a lot of therapies like physical therapy, acupuncture, chiropractor, exercise, strength training, resistance training, biofeedback, cognitive behavioral therapy that can reduce headaches. And then, of course, the lifestyle changes that we talked about on the last slide, that can help reduce and lessen your headache pain. So there's quite a lot that can be done, and it is not a grab bag, meaning if you see your provider, you are not going to just be given 20 things. Your headaches are going to be assessed in the context of you and your own health conditions, and a treatment plan will be developed that's specific to you. So it's not a generalized recipe. It's really a specific approach for each patient and their conditions. So frequent headaches may be your body's way of alerting you to a problem, but it does not necessarily always mean that that problem is something scary or dangerous, like a tumor. And I do urge everyone to prioritize yourself and your health. And the reason being is because you want to be the best you can for whatever matters to you in life, whether that is your work, your career, your family, your friends, your social engagements, or enjoying life. But you are going to miss out on some of those things if you don't prioritize your health, and that includes headaches, even if they're common and everybody has them, so to speak. You need to advocate for yourself in the healthcare setting. If you don't feel like you're being listened to by your primary care doctor, or you want a referral to a neurologist, advocate for yourself, and use your own knowledge and your symptoms to make sure that you get the best care that you can. Find a provider you trust and you can communicate your concerns to, and whose advice and recommendations you follow. You certainly don't want to feel like you don't have an option in who you see. You want to make sure that who you see understands you and your symptoms, and that you understand why and what they're recommending for you. So if someone tells you, I think you need a scan, that you feel like the scan is appropriate and what it's looking for, or why you need a scan, or why they are recommending a medication or a therapy. So don't be afraid to ask questions to your provider and have a good relationship with your healthcare provider. And lastly, don't ignore symptoms or concerns. Try to listen to your body. Because sometimes people tell me that they toughed it out for a long time and it got to the point where it's so bad now.
All right, everyone, let's see, we're experiencing a little technical difficulties. Just give us a moment while we get Dr. Evan back on the call. Yes, the PowerPoint will be provided in the form of a recording for the seminar. So stay tuned after it's concluded. We'll be emailing that out to everybody. All right, everyone. Let's say we're still experiencing a couple technical difficulties with the doc. But I think we were wrapping up the presentation. Rest assured that we will make sure that everybody who registered will get a recording of the presentation from today, and then also we'll send out the slides as well once we get those over from Dr. Evan. I want to thank everybody for taking the time to join us today. Everybody who's out there, if you have any questions or any concerns, please feel free to reach out to us, wellness@transitchicago.com. Please enjoy the rest of your day. Have a safe weekend, and definitely reach out if you have any questions or concerns.